Well, it's my honor to introduce Dr. Loretta Jophlin today. Loretta is an assistant professor in the Department of Medicine and other of her affiliations. She's medical director for liver transplantation, which I think is super impressive. She's a graduate of the College of Charleston, where she won Outstanding Biology Student Award and numerous other academic accolades. And she also received a number of awards as a medical student in the MSTP program at the Medical University of South Carolina, including her being PI on an NIH P30 training grant that was entitled Interactions Between TGF-beta and Retinoid Signaling. In 2022, she received her MD and Ph.D. degrees, and then she moved north to New York City to Mount Sinai, where she completed a residency in internal medicine, and she was Intern of the Year in 2012. She returned to South Carolina for a fellowship in gastroenterology and hepatology, and during that time, she received an F32 NIH fellowship. So she's really tracking along these NIH fellowships, which speaks very well for her research capacities. In 2017 to 18, she completed a transplant hepatology fellowship at the Mayo Clinic in Rochester, Minnesota, so I know she had some cold weather up there as well. She spent a year as an assistant professor at the University of Nebraska before she was successfully recruited to the UofL in December 2020. She's mentored residents and medical students and fellows and pre-MD students. She has at least 28 peer-reviewed publications from what I could discern from PubMed, and she's on the editorial board for the Journal of Lipid Research. She's currently PI on an NIDDK KOA Career Development Award that's entitled Interaction of the Microtubule Cytoskeleton and Paralipin-2 Regulates Hepatic Lipid Droplets, a potential therapeutic target for fatty liver disease. She's a member of the Center for Integrative Environmental Health Sciences multi-organ toxicology group and has an interest in liver fibrosis and identifying druggable antifibrotic targets in PASH. But today she's going to talk about a different topic, and it all relates, but let you talk about that. So welcome and thank you.
Thank you very much. I appreciate that. So I am kind of trucking along the career development pathway, and hopefully I'll establish myself as an independent investigator soon. In coming to the University of Louisville, I've joined the groups of Dr. Matt Cave and Dr. McLean, and they have an area of excellence in environmental liver disease. I'm learning more and more that there's a number of xenobiotics that likely impact our metabolism and likely impact the trajectory of somebody who might have pre-existing fatty liver, and that can be accelerated towards advanced fibrosis and cirrhosis. So it all ties back in. The goal is to, not have to do liver transplant because we don't get liver disease anymore. So this talk is about sodium benzoate, and it really was born out of a conversation that I had with Dr. Matt Cave in 2019, and it's turned into a really interesting project, and serendipitously it has linked back in with some of my K08 research, which my program officer is really happy about. So here are my disclosures, none of which are relevant to today. So I'd like for us to briefly discuss the role of xenobiotics in consumable preservation, talk about metabolic impacts of xenobiotic preservatives, what is known about them, and explain the effects of sodium benzoate in particular and its ingestion at the levels that human beings ingest this chemical on an animal model of fatty liver disease. So I'd like to start out with a clinical case. And this clinical case happened, and others like it have happened. A 54-year-old gentleman referred for an incidental finding of hepatic steatosis on an ultrasound of his abdomen that's performed for abdominal pain. His local GI doctor started him on a proton pump inhibitor and changed his diet to avoid spicy foods, and the pain resolved. That now we're dealing with another diagnosis, which appears to be hepatic steatosis. No past medical history, no surgical history. He's a non-smoker, does not drink alcohol, does not use drugs. 2 healthy children, has an administrative job. Protonics is his only medication. He does snore at night and he has daytime fatigue. His vital signs show a little bit of stage 1 hypertension. He is technically obese with a BMI of 35.1. Labs show reasonable kidney function and nothing that is striking about his liver showing inflammation. Platelets are 310, which makes me feel better that he doesn't have advanced cirrhosis and portal hypertension. But in physical exam, he has dental caries and truncal obesity. So I look at what he's eating, and for breakfast snacks, lunch snacks, dinner snacks, most of it is made in a factory. Ultra-processed foods. Some things he is trying to eat organic, but organic labeling can be placed on ultra-processed foods. There's very little regulation over the term organic. He has pre-packaged sandwiches that have shelf lives of weeks rather than days. He eats a lean cuisine, which has a shelf life of over a year. Yogurt and ice cream. His daily caloric intake is too high for his basal metabolic rate and his level of activity. So in looking at his physical activity, he spends most of his time sleeping, watching television, and doing a desk job. And so his MET, which helps us to determine how many calories he's burning a day, is on the light intensity of activities. So he might as well be spending most of the day in bed. So what do we do for somebody who has obesity and hepatic steatosis? I talked about this last year when I gave grand rounds. I ordered a fasting lipid panel, a thyroid panel, a hemoglobin A1C, viral serologies, an iron panel, alpha-1 antitrypsin, autoimmune panel, and a FibroScan of the liver. I gave him the goal of losing 5 to 10% of his body weight over 6 months at a rate of 1 to 2 pounds per week, and I referred him to a dietitian. Due to his snoring and daytime fatigue, I ordered an overnight pulse ox sleep study. And then I sat down and did a dynamic weight loss modeling on the NIDDK using the body weight planner, which I've started to use more and more with my patients. And so on this website, you can type in your weight, sex, age, height, and estimate your physical activity level based on those METs. The goal weight based on this 10% body weight loss, and the time to achieving that goal. And how would you like to achieve the goal? Would you like to restrict calories or do more physical activity? What is going to be more painful for you? So ultimately, I felt restricting his calories would be most effective and increasing his activity by 10 to 15% would help him achieve this. So 6 months later, he comes back in and his weight has not changed. He's been prescribed CPAP for daytime, for this obstructive sleep apnea as daytime fatigue has improved. He started going to the dentist and using mouthwash. He gained a couple pounds. He's discouraged because he's cut his calories by changing all of his full sugar drinks to sugar-free. He's swapped his snacks for lower calorie ones and eating a lot of bagged salads. He couldn't get an appointment with a dietitian, so he just cut as many calories as he could because calories in equals calories out, right? So his follow-up food logs, he is taking in less calories, significantly less calories. Part of me believes this food log is not correct. But he has swapped out ultra-processed foods for more ultra-processed foods. And he has changed his Big Red, which is a soft drink, to a sugar-free formulation. So we do a FibroScan on him, which looks at not only the fibrosis level, the liver stiffness measurement, but also the measurement of how much fat is in the liver. And at day 0, the 249 that you see is the measure of liver fat. the 6.8 that you see is the measure of liver stiffness or fibrosis. And so he's on the borderline. Anything above a 8, or the orange number, is considered as clinically significant fibrosis. And any CAP or steatosis that's above around 250 is significant hepatic steatosis. So on day 180, things have gotten worse for him, unfortunately, as they do. So what happened is this extra 2 pounds edema from increased salt intake. He's cut calories, but not to sacrifice flavor. Are the food logs inaccurate, as they often are? And is it something non-caloric that he's taking in? So he was not happy with that appointment. He eventually went to the dietitian and started a whole foods diet, avoiding all preservatives. He did no change in his caloric intake, even though we didn't have accurate food logs. But he lost 20 pounds in the next year, and his CAP score, the liver steatosis, improved to a level that's not concerning. So what happened? Was it the change in the ultra-processed foods? So when I looked at Big Red, I didn't know what this was. I thought that it was a drink that was the beverage of choice for the Cardinals because it's red. And it's often advertised at the Cardinal Stadium, and there's actually a Big Red Day in Louisville that celebrates this beverage, even though it's made in Plano, Texas. But it's the only beverage that I've ever seen where the second ingredient after water is a preservative. You might have smelled a derivative of sodium benzoate before if you've ever taken a fit test for an N95. There is a benzoate moiety that is extremely bitter, and not only is it a preservative, but it is a flavor enhancer because they can make the sugared version of Big Red without this preservative. You would think that sugar in the beverage would lead to more spoilage, and so I've asked the makers of Big Red why the discrepancy in the use of this preservative, which I believe is a flavor enhancer, and they did not have an answer for me. So going back to 1905, there was a concern about preservatives on metabolism. We'll talk more about what a preservative is, but if something stops the growth and metabolism of a microbe, could it potentially stop the growth and metabolism of a human being or a mammal? This was proposed back in 1905. So preservatives are substances that we add to consumable products that have a shelf life. It can be things we eat, put on our face, shampoos, to prevent spoilage from microbiota, including bacteria and fungi. The food preservative industry is $3.2 billion. So this is just the sales of the chemicals that are put into foods as preservatives. This is not companies that do flash freezing. This is not the canning industry. This is just the xenobiotics. And by 2033, it's going to be a $5 billion industry. So the food preservative industry actually is worth more than the food waste, the amount of waste that we have. So consumers do regularly waste about 20% of the food that we buy at the grocery store. It goes straight in the garbage. Alternatives to chemical preservatives are to heat things up, to bring home food that is frozen rather than fresh, because it can stay in your freezer. There's 47% less food waste than if you purchase fresh vegetables, for instance. Upcycling, which is taking our food waste and turning it into compost, or taking the rotten banana and turning it into banana bread, those sorts of things. And then local sourcing. Food preservatives are really helpful if you're shipping something from here to Europe, Europe back, China, all over the world. So if we were to eat local, maybe we'd use less food preservatives. There's not too much out there about this. I don't know that mainstream, transplant hepatologists have really dug in, but so the classes of preservatives, there are 3 main classes: antimicrobials, antioxidants, and chelating agents. I'll focus on the antimicrobials. Benzoates, sorbates, propionates, and nitrates you might have all heard of or seen on the food labels of the things that we eat. So the benzoates can be potassium benzoate, sodium benzoate. Benzoic acid itself can be placed into foods to act as an antimicrobial. Sorbates, potassium sorbate is the most common, and the propionates, which I didn't know that much about until I started investigating for this talk, actually are the ones that have the most evidence for having deleterious metabolic effects. Nitrites we know quite a bit about because they do have an association with gastric cancers, populations that eat high amounts of meats that are preserved with nitrates. It's very harmful. So the other antioxidants that inhibit oxidation, vitamin E and vitamin C, I'll just say that ascorbic acid, when in the presence of benzoic acid, forms benzene. And we know that benzene is a carcinogen. They both often go into beverages together. There was an investigation about the unsafe level of benzenes in beverages that was probably overblown. But about 1% of all beverages tested did have benzene that was beyond the upper limit of what is considered safe. So this was published in 2019, and it really took it took the food preservation industry by storm. There was a decrease in the propionates that were used, and you can see an uptick on the use of benzoates after this was published. But this particular preservative did show in mice and in humans that you have changes on FABP production, glucagon, and impaired insulin sensitivity. So a second article that came out more recently on this that actually performed a randomized placebo-controlled trial on this preservative showed deleterious metabolic effects in human beings. And so I look for this to be the next chemical that might come off of the FDA food additive list as generally recognized as safe. It takes about 10 years to get something out of the food supply that is considered to have a harmful signal. So in looking at what's published on sodium benzoate, it's less robust. This was a paper from 2015 that's cited in a lot of review articles demonstrating that sodium benzoate is safe. And what it was a small trial on individuals who drank boluses of sodium benzoate over a course of 2 days, and basically having the equivalent of 6 to 10 sodium benzoate containing big reds a day. And the bottom line is that there was no change in this 2-day period of time of ingestion in plasma glucose or in serum insulin when you give it with or without glucose, with or without benzoate. So it kind of put things to rest for a bit. And there was an article that came out in 2017 talking about sodium benzoate as being, it's not easy to study its toxicology because it is so non-toxic, as a soundbite from this article. It was also said the effects on cells in culture as well, although at levels that would seem to be difficult to achieve in vivo. They said that this, the amount of sodium benzoate that's going into our food and our beverage is safe. The reason why this scientist, who's relatively well respected, wrote this article, Derek Lowe, as a commentary in Science journal, is that Panera Bread Company said that they were going to take sodium benzoate out of their products. This individual thought that it was some kind of a marketing stunt and said that they disagreed with Panera blowing this up, and sodium benzoate is safe. So a few years after that article was published, in the mid-2020, I was talking to Dr. Cave about some preliminary omics work that was done looking at liver fibrosis out of one of, I believe it might have been some serum from NHANES, showing that there was a benzoate moiety associated with hepatic fibrosis. It was later, this data was looked at, and it's still unclear what the benzoate moiety is. It may be copper benzoate, but that conversation was enough for me to go to my lab shelf and say, oh, I have sodium benzoate here. We use it in a lot of our buffers so that they don't grow mold. I'll just throw it on some hepatic stellate cells and see what happens. So I looked at the literature, and I saw the circulating concentration of sodium benzoate that healthy volunteers in clinical trials where sodium benzoate was used for schizophrenia or other uses. What is the plasma concentration? And I just spit that on the cells. So cells treated with vehicle versus fat, which tends to make them quiescent, treated with sodium benzoate at a non-toxic concentration that's physiologically relevant, and with the addition of fat. And not too many things other than TGF-beta, which I studied for a long time, can really increase the alpha smooth muscle actin and the migration of hepatic stellate cells. But I saw that this low concentration of sodium benzoate did, which was quite interesting to me. And I filed it away that this could be something that potentially does propagate fibrosis, and maybe the signal that was seen in the omics study was real. Dr. came back to me later and said, don't look at that anymore because we reanalyzed the data and it wasn't statistically significant, but I was already down the rabbit hole at this point. So looking at sodium benzoate, it has a Wikipedia article, as any good food preservative does. Most of them do. Citations on the mechanism of action of sodium benzoate: decreases intercellular pH. It becomes benzoic acid in aqueous solution, and it reduces the pH much as vinegar does. You know, vinegar slows microbe growth. Sodium benzoate does that, but more robustly. There's some evidence that it slows the activity of various metabolic enzymes, inhibiting glycolysis and causing growth restriction by restricting ATP production. It can keep an item shelf stable for at least 2 years from the date of purchase, and it's generally used in concentrations of less than 0.5% by volume. It has been used as an ammonia scavenger, as it leads to the excretion of glycine. And glycine is an amino acid precursor that can feed into ammoniogenic pathways. I've used this in my patients that have end-stage liver disease with brittle encephalopathy. I remember at Mount Sinai Hospital giving patients sodium benzoate when we had nothing else to offer them. I don't know that it ever helped. It's also as an adjunct to treat schizophrenia, dementia, early psychosis, and it is a monoamine oxidase inhibitor, very similar to some of the tricyclic antidepressants that we have. It has robust central nervous system effects, and it has been, there's some publications that it can be associated with hyperactivity in children, ADHD, and things like that. So this is the monograph from the FDA. It was published in 1977, amended in 1984, revised in 2020, showing that sodium benzoate is generally recognized as safe, and nothing has truly been revised or updated in it because I've looked at the ones from 77 and 84. So all of the data that has come out into the literature about this potentially having a harmful signal has not made its way to the FDA. So I alluded to benzoate metabolism, and the pink double line here is the mitochondrial membrane. So benzoate and CoA are taken up together, and there is an enzymatic reaction where the CoA and benzoate come together to form benzyl-CoA, which theoretically could lead to a sequestration of CoA in the cells, and CoA is very important for beta oxidation and a lot of other processes. until glycine comes along. And glyat leads to the excretion of benzoic acid in the form of hepurate, and then CoA is freed back up. This was actually, sodium benzoate was used as a marker of hepatic function in some human studies in the 20s and 30s, because the thought was that if you have intact hepatic function, since this all occurs in the hepatocyte, you have one sodium benzoate in, one hepurate out. It was found that cirrhotics only excrete about half of a bolus dose. So what happens to that other what happens to the benzoate that doesn't get excreted? That's a good question. So how much sodium benzoate are we actually exposed to? It is in a lot of processed foods. We have a lot more than we did in 1977 when the FDA monograph came out, and it was generally recognized as safe. Since then, we've had an obesity epidemic in the same time frame. People have more obesity, diabetes, and it's perhaps in 1977, sodium benzoate was safe. Safe for that population. I don't know that it's safe for the population we have now. The World Health Organization has recommended that the ADI be no more than 5 milligrams per kilogram body weight, and this is based on animal studies. Animal studies of lethal doses, as well as doses that lead to liver and kidney dysfunction. So one 12-ounce soda does have 4.5 milligrams per kilogram body weight. In the United States, individuals who are having a highly processed diet, in the 90th percentile of benzoate consumption, they're taking in 7 times the recommended daily limit. So it's in just about everything. I went through my house and I just took pictures of the things that sodium benzoate was on the ingredient list. And unfortunately, a lot of medications, the children's dye-free pain and fever, you think you're doing, a good thing by giving them something that appears to be more organic or maybe less xenobiotics in it. But sodium benzoate is in there so that you can have a longer shelf life. And it might be in there to make it taste better. Pasta sauce? Where? The Diet Cola. This is Maker's Mark cherries. Yeah, just like a preserved cherries. So these are the preservative market trends for personal care from 2009 to 2019 in cosmetics, shampoos, body washes, all the things that we put on our skin. The rate of sodium benzoate use has just about doubled as the preservative of choice, as some of these other chemicals, the propylparabens, are less used. The thing is that if you look at sodium benzoate, it's a benzene moiety. It's very similar to a paraben, and parabens have been kind of ostracized, but sodium benzoate has not yet. So there are papers that sodium benzoate can impact mammalian metabolism. In looking at liver homogenates, decreases of ATP, CoA, and acetyl-CoA were seen at these physiologic doses of sodium benzoate. That was reversible by L-carnitine, so it's acting directly at the level of beta oxidation. And then in rat models, sodium benzoate used at slightly higher concentrations of those in human clinical trials. It can decrease glutathione and superoxide dismutase metabolism. So increases in serum markers of hepatic inflammation and decreased hepatic function have also more recently been reported in 2020 in a rat study. So my next step was to look to see if sodium benzoate promotes fat accumulation in hepatocytes. If there's evidence that this slows down beta oxidation, then the next step would be increase in lipid droplets on the lipid droplet person. So in treating HUH7, which are hepatic adenoma cells but behave pretty similar to hepatocytes, they tend to have very little fat at baseline. The green is Bodippi. When you treat with oleic acid, you get an accumulation of lipid droplets. When you treat with sodium benzoate itself, there was some accumulation. Fat and sodium benzoate together leads to some accumulation of fat. And these higher concentrations of sodium benzoate lead to larger lipid droplets and more steatotic cells. So these are cells by themselves, but when you co-culture them with hepatic stellate cells and you recapitulate the crosstalk that occurs between these two dominant cell types in the liver, you'll see that there's just a profound amount of steatosis that it can accumulate with sodium benzoate by itself. No additional calories, no additional fats or sugars. And so in quantifying this, the co-culture that is closer to, what you would see in vivo showed steatosis. And so we looked at the seahorse assay and looking at the same cell type in a dose-dependent manner, this 6 millimole and 12 millimolar, there was a blunting of beta oxidation over a period of time as measured by your oxygen consumption rate. And so that was enough preliminary data for me to take this into an animal model. And so we looked at males and females. Looking at females has confused me, but I think that it shows there are some sex-specific differences. But nonetheless, we assigned them to a control or a high-fat diet and pre-fed them this for a period of around 6 weeks. I didn't want them to become overly steatotic because once you have too much steatosis in the liver, you really can't see differences. So we gave these animals by gavage the equivalent of 6 sugar-free Big Reds a day in sodium benzoate by gavage for 28 days. And then we looked at glucose tolerance before and after. We looked at echo MRI, which measures the lean to non-lean ratios. Unfortunately, all the diets that we had contained 0.11 grams per kilogram of P-amino benzoic acid from Teclid. That is a preservative that they use. And so there was, and P-amino benzoic acid can be converted to benzoic acid very easily. So there was already a background level of this preservative in the system that we could not get rid of. So very similar to some of the other negative data, the animals did not show too much of a significant weight change. Animals on a controlled diet, males and females, with or without sodium benzoate, really had kind of overlapping profiles. What was interesting is that some of the high-fat diet animals tended to lose a little bit of weight. The further out we went, I don't know if they weren't feeling very well or if they were having some of the CNS effects that you can get from benzoate exposure. And as I said, in all of the animals, there tended to be a non-significant decrease in body weight when sodium benzoate was gavaged. So really no difference overall in the males over the time period that we looked, not that much of a difference in females either. So when you look at the male fat to lean body ratio using the echo MRI, there was a significant difference in the high-fat diet-fed animals compared to control diet. And this difference here with adding sodium benzoate to the high-fat diet was nearly significant. I had 5 animals in each group, males and females, so it was a small pilot experiment that more numbers would probably be helpful here. There was really no difference in the white adipose tissue with the addition of sodium benzoate. Really no difference in the change in fasting glucose either, as well as at the end of study GTT. So cholesterol, no difference, HDL, no difference, triglycerides, maybe a difference in LDL, but if you were to look at these data on the surface and even publish this, it says, okay, well, sodium benzoate doesn't cause a problem in this chronic administration. So, not too exciting. But as a hepatologist, I had to look at the livers, and it's really important because that's where sodium benzoate's metabolized. So looking at these transaminases, which are markers of hepatic inflammation, also not terribly exciting. Maybe an increase in AST in the high-fat sodium benzoate treated animals. And then the liver, the body weight ratios didn't show much of a difference either. But then when we looked at fibrosis, which was that original signal, we saw some pretty interesting differences. So this is a control diet, high-fat diet, which these animals don't get much hepatic fibrosis in this period of time on this high-fat diet. The control diet with sodium benzoate gavage has developed pericellular fibrosis, wrapping around the hepatocytes throughout the sinusoids. And I tend to show data that are less impressive. I have areas of these animals where they have nearly bridging fibrosis after 28 days. And what I wanted to show was fibrosis here in the high-fat diet, sodium benzoate gavage. And you'll see that there are the pericellular fibrosis, but you see just a lot of zonal fat that has accumulated with the addition of benzoate. So in looking at our fibrosis markers, alpha smooth muscle actin and collagen 1A, I've been doing fibrosis experiments for quite some time, and it's really hard to get ACTA2 upregulated over 28 days for anything, including carbon tetrachloride. But these animals, just with sodium benzoate gavage, are expressing this fibrotic marker that really is a marker of activated hepatic stellate cells that are lying down by fibrotic material. And then collagen 1A1 did show a trend as well. So steatosis, in looking at our control diet water gavage animals, you see that oil red O staining, which stains neutral lipid, is present in some small lipid droplets even in our control animal, not uncommon for males that are adult to have fat in their liver. On the high-fat diet, this was not a robust amount of fat that's laid down. Like I said, I wanted to see differences. But with sodium benzoate gavage, the livers became highly steatotic. Some of them became almost completely replaced with fat. With the control diet and sodium benzoate, there was some additional fat accumulation, but it really was accelerated on the high-fat diet. And this is our quantification of liver triglycerides. So I just want to show you, I like to show all the data. These are animals on a high-fat diet that were not given sodium benzoate gavage. This is their liver. You can see kind of a modeled pattern as you do with steatosis. Some are more affected than others, but when you add sodium benzoate to it, you have a profound change in the livers of these animals. So I went on to an exploratory journey looking at cytokines that might be changed. While I know something about sodium benzoate metabolism, I think there's probably more going on than we appreciate. And so control diet, sodium benzoate, high-fat diet, and then high-fat diet on sodium benzoate, there's changes in resistin, in periostin, and IGF-BP2. These are a lot of pathways that I don't study, that I probably need some help with. A number of other leads of players in these pathways of inflammation, such as IL-6, did show some trends with sodium benzoate. VEGF-A appeared to be globally increased with sodium benzoate regardless of the diet. CXCL10 was decreased with sodium benzoate, and SIRT2, which is a histone deacetylase, regulating transcriptional changes, appeared to be quite blunted by sodium benzoate. And these are looking at the livers and mRNA in the liver. I'm a cell biologist. I like to see cells. I like to see proteins. I like immunohistochemistry. And so I'll show you some of that data here in a bit. So around this time, there was a publication that came out showing a novel post-translational modification called lysine benzoylation, which this benzoyl motif can attach to lysine similar to acetylation motifs. And that lysine benzoylation occurs in histones, and it is written and erased in a similar manner as acetylation is, and that it is a transcriptional regulator. Their studies showed that the lysine benzoylation occurs in areas that regulate metabolic effects. They studied HepG2 cells, but they didn't get too far into an animal model. So wanting to visualize benzoylation, there is one antibody company, they're called PTM, post-translational modification, and they focus on novel post-translational modifications, trying to make excellent antibodies to measure them. And so these are hepatocytes, HUH7 cells that I treated with oleic acid, with sodium benzoate, and with a combination of both, and looked at CK18, which is a cytokeratin that is common in hepatocytes. It's actually exclusive to hepatocytes. It's not really expressed anywhere else in the body. And then looked at benzoylation. And what I found that was quite interesting is that whether it's background expression or maybe expression localized to the cytoskeleton, the benzoylation had an interesting sort of background appearance. When you treat with sodium benzoate, I hope you can appreciate that there is a profound increase in the benzoyl signal into the cellular nucleus, which may very well represent that histone benzoylation. So at this point, we reached out to Dr. Merchant to take some of our livers from our animals, actually all of our livers. We pooled all of the samples from the males and from the females from the 4 treatment groups, the control, the high fat, the control with benzoate, and the high fat with benzoate, and asked him to look at all of the proteins that are expressed, but also the post-translational modifications, particularly benzoylation. And we expected, as a positive control, we would see histones, just as was previously reported. And these here are all histones. These 4, as you can see, in the sodium benzoate control males, high levels of benzoylated proteins. But what we found that was also quite interesting is that keratins, keratin 1, 8, 18, just like I saw in my immunohistochemistry, also appear to be benzoylated. What I cannot completely explain, and I'm surprised it's not already been published in the literature, because something this significant and novel, when I'm looking at it, doesn't seem possible, but maybe it is that ribosomal proteins also appear to get a benzoylation motif. Why is there lysine benzoylation that's seen in the high-fat diet or the control diet? It's possible that this is benzoylation from the feed. It's possible that lysine benzoylation is a part of normal metabolism, and that we are just getting more of it when you put sodium benzoate into the system. So the effect was not as robust in females. It was not as interesting, but I didn't show what happened to their livers, and it looks like there is a sex-specific effect. So the working model, besides the benzoyl post-translational modification that feel like we need to focus on. Looking at our benzyl-CoA and the sequestration, taking CoA out of the system. Is that done in a way that blunts beta oxidation? And looking at our cells, treating with oleic acid, sodium benzoate, and then the combination of sodium benzoate and fat, there is a decrease in the relative CoA levels. What I couldn't explain before I had more data is that it looks like free CoA goes back up with sodium benzoate at this concentration, but what I found is that this was likely secondary to cell death, and that sequestered CoA was then free. And so back to our working model, glycine. We capitalize on taking glycine out of the system for hepatic encephalopathy so that it doesn't form ammonia. But does taking glycine out of this system lead to a decrease in other amino acids that are really metabolically important? And so looking at the livers of our animals, looking specifically at glycine, you would expect with sodium benzoate you would have less glycine because it's being used and excreted. But there was only a trend and nothing significant. But looking at all amino acids, and we looked at 23 of them, sodium benzoate with the control diet led to a decrease. Similar that you know this happens in a high-fat diet. You have a relative decrease in amino acids, but sodium benzoate caused it on its own. And looking specifically at glutamine, which is important in non-alcohol steatohepatitis, we know that oral supplementation of glutamine can reverse NASH in animal models. And we see that there's much less glutamine in our animals that have NASH from high-fat diet and also may have NASH from sodium benzoate itself. And so in conclusion, these data are quite preliminary. I have a lot more work before that. I'm absolutely convinced that sodium benzoate is causing a problem. I know with some confidence that it is upregulating hepatic fibrosis. It does promote hepatocyte lipid accumulation in vivo and in vitro. It appears to blunt beta oxidation in hepatocytes by decreasing the oxygen consumption rate as assessed by seahorse. I would like to put these animals in metabolic chambers. Sodium benzoate does decrease free hepatic amino acids, particularly glutamine, and it leads to benzoylation of proteins. We know it can do this to histones, but keratins and ribosomal proteins also appear to have this new posttranslational modification that I think we need to understand. So it's not just in our food anymore. In October of 2020, the EPA has said that using sodium benzoate at concentrations up to 3% in water, as well as in detergents, emulsions, baby wipes is acceptable. And so this is a brand new brand. It's called Calagar. So be on the look for it. It's going to show up in a lot more things. Sales are going up, and it's been labeled as this green and non-harmful alternative to using pesticides that might have bioaccumulation. But I would say that if we're getting post-translational modifications, maybe we bioaccumulate as well. So this is just for fun. These are HUH hepatocytes treated with standard media, and I took 20% Big Red Zero and put on them for 18 hours, and they didn't die, but they got really steatotic. So I'd like to acknowledge the CIEHS, the EM Corps, the Kentucky INBRE, as well as other people who have helped me, like Dr. Merchant and Dr. Barati with some of this microscopy, my lab members, my mentors, and outside collaborators, including the UC Davis Amino Acid Lab. I'm happy to take any questions.
It's really interesting. Thank you.
Oh, yeah.
Have you thought about looking at selenium levels? High-fat diet, sodium benzoate or sodium benzoate.
Why do you ask that?
Why do I?
Yeah.
Slower proteins are protective as antioxidants, and I would think with the fibrosis, oxidative damages. In my work with Matt Cave and the high-fat diet PCB, or long-term low-fat diet PCB, selenium concentrate. Working on identifying potential changes in selenoproteins.
Okay. So I was trying to, in doing this proteomics experiment, selenium binding protein showed some differences that I couldn't explain, and I don't understand much about selenium metabolism, so maybe we can talk.
Yeah, sure.
Awesome.
The high fat plus the sodium benzoate, that had less of a benzylation.
Yes. And
so what was that? Why was that?
I've seen that in cells, and I've also saw that in the animals. I can't completely explain that yet. Why why it's being removed. Something about putting lipid into the system.
Because in terms of the fibrosis, it actually increased.
Mm-hmm.
But benzylation is different.
Right.
Right.
Yeah, that's something that I don't completely understand, and I'm glad you've noticed it, because I noticed it with my eye as well, and yeah.
Also, said that it improves glucose. One of the things that it been.
Yeah.
Is there an explanation?
So it's possible that you're having to rely more on utilization of glucose rather than lipids. If you're shutting down beta oxidation, but you're not shutting down, other pathways. We've seen this with some other exposures in the lab, like fluorine, for instance. The animals become quite hypoglycemic. Ours weren't frankly hypoglycemic, but it didn't increase insulin resistance. It didn't change our AUCs at all.
And are these changes very specific to the liver? Other organs also?
I haven't looked at other organs yet. For these animals, we did our best to utilize the animals for future studies. I know Dr. Barati has the kidneys right now. I did see a paper that came out showing sodium benzoate effects on the kidneys relatively recently. We have small intestine. I think there's going to be changes in the microbiome. This is an anti-fungal agent. It's an antimicrobial. There was a paper published a few years ago, and I think there's something in the chat about this. Can you comment on the contribution of the microbiome to metabolism of benzoate and how that could affect your data? Yes. So in the years that we have been increasingly exposed to sodium benzoate all the time, there has been a shift in our microbiome based on that, and there was a paper published a few years ago showing that. What does that mean for us? I don't know.
So thank you for the excellent talk. This is Swapna. It's really, really groundbreaking work, I think, considering how ubiquitous sodium benzoate is. I was wondering if there are food products out there that have sodium benzoate in it that are not required to be labeled with it. Is there like an amount beyond which they label it?
So the FDA has said that this cannot be in products any more than 1% weight by volume, and it has to be labeled, no matter how much is present. For unclear reasons, so Arby's pickles, if you look at the label, it says sodium benzoate 3%. By stating the concentration, they are somehow getting around the recommended amount per the FDA. So sodium benzoate is naturally occurring in some fruits and vegetables. You might have noticed that cranberries stay good forever. They have a high amount of naturally occurring benzoic acid within them. So does that answer your question?
Yeah, I mean, it does. I just want to make sure that people are not consuming sodium benzoate if they're vigilant about it just because it's not labeled. If it's less than 1% and it's added, it's a FDA mandate to label it, or is it that beyond, if it's 0.5, they don't have to label it or something like that?
No, it has to. With all food additives, my understanding of looking at FDA policies, if it's added at all intentionally, it has to be labeled.
Okay. Yeah, it's okay. That does help. Thank you very much, and good luck with your future research.
Thank you. Thank you.
So Steve Winters here, question from here. So very nice and provocative data. Just first a comment and then a question. So the comment was that I noticed that your patient was very short, 5'2", which puts him way below the 5th percentile for Caucasians, if he was a Caucasian. So one wonders whether he was growth hormone deficient and whether the growth hormone deficiency would have contributed to his metabolic disturbance. So that's the comment. And then the question is, so I was intrigued by the sex difference. Why do you think males were more susceptible to females? And it brings me back to an experiment I helped with more than 40 years ago, where one of my colleagues found that clofibrate was a peroxisome proliferator only in males. And my job was to take off the testes from the experimental animals and then measure testosterone levels, which of course went to very low. So removing testosterone eliminated the biological effect of the clofibrate. So I was curious what you think about the sex difference that you described.
Yeah, I'm just looking back to our gentleman who was shorter than average. When I was at Mayo, I did measure growth hormone axis. Here, I've thought about doing it, but it's very difficult to get some of these labs, and I really wouldn't know what to do with them. I'd probably just send them to endocrinology. In people who are young, or people who have the fatty liver disease that I cannot explain how aggressive it is, that are particularly short, I will start exploring IGF levels. For the sex differences, in looking at the males and the females and the proteomics, I'm just starting to get into that, and the string analysis that I've done on males and females is very different. Very different pathways appear to be changed with the sodium benzoate on a control diet as well as on the high-fat diet. The males have a major urinary protein, which I don't know that much about it. I do know that it's something that males that are under periods of stress can upregulate. With sodium benzoate exposure, there's a lot of upregulation. They were gavaged. Similarly, they have the same handling stress, but that's one difference. And then it's a 17-hydroxysterone, I believe, is extremely upregulated in females on the control with sodium benzoate. They have less steatosis, but they have some vacuolization throughout their liver, as well as what appears to be depletion of glycogen, more so than the males. So I'm still trying to sort that out. Thank you for that question.
So there are people who looked at if the patient went back to.
I mean, I know I've fallen off the wagon of good health, eating organic, trying to eat less meat, and but ultimately the same amount of calories. And it's a feeling, but it is also, I feel the weight creeping back up, anecdotally speaking. I don't believe calories in or calories out.
So what about the benzoate?
The benzoate, if an ultra processed diet with high amounts of benzoate, are playing a role on our ability to not only metabolize the calories that we eat, but also having more of a long-term effect on our epigenome, then what I would really like is to look at, my idea for a trial would be to go to the grocery store and look at people that are shopping, and the ones that are buying a bunch of ultra processed, hand them a flyer and say, hey, can you come and give me a blood sample or a hair sample, whatever. I can look for benzoylation and some of the other things that I've seen in the mice. I would never willingly do the trial where I make somebody drink this. I would never put somebody on a high benzoate diet because I think it's unethical. So it's going to have to be.
In your animal experiment, have you stopped the benzoate and then followed them?
So like a washout?
Mm-hmm.
Yeah, I could do that. I've done that with cells, where they're treated with like pulse dose sodium benzoate, and then how long it takes for the benzoylation signal in the nucleus to disappear. And I haven't had a washout period long enough to get it out of the nucleus. So I've taken it out to weeks now. But eventually I start to have the cells overgrow and you trypsinize them. So I think it takes a really long time. I'm looking at the writers and the erasers of the benzoylation. So the CAT7 or HPO1 is the writer, and the eraser CERT2, possibly CERT1, and trying to do knockdowns of those to see if that actually has the same effect on steatosis as sodium benzoate itself.
Lifelong
Yes, it would be very interesting to look at the benzolome of those individuals. Mm-hmm. Yeah, I have a PowerPoint I can show you here in a minute where I've taken all the labels of MREs and found which ones have sodium benzoate, which ones do not. It has less sodium benzoate and more potassium sorbate. They do use it in certain, like their beef stews and other sort of savory meats. So I wanted to try to get a VA study going on with this, but my data was not quite mature enough to move into the most recent call for proposals. What is more concerning is that there's a lot of sodium benzoate in the energy drinks, and energy drinks are more so consumed, and also like Monster Energy drink is like the official drink of various battalions, and it's purchased and sponsored, and so they're drinking a lot more of it. I think that would also be important to look at. Yeah.
already they're starting to have studies correlations. Mostly exam.
Yeah, I mean, if their food is going to be ultra processed and they're going to zero gravity, which we know has metabolic effects, they could potentially become quite ill in that time frame. So I would hope that the medical staff takes those things into consideration. I'm kind of more concerned about Portland and Shively. Those kids don't have access to fresh fruits and vegetables, and sodium benzoate is put on their lunch trays every day, as well as other preservatives. I think the ultra processed diet, anything that we can do to reduce it, but even we think we're eating healthy. The baby carrots that we eat and give our kids are washed in this. They don't have to put that on the label. It's washed off. So I know I can't say, I don't know what to call it anymore. I'd say a disadvantaged food landscape is right under our own noses.
Thank you very much.
Thank you.